Hi, thanks for joining us today. My name is Marian Hart. I'm with Indiana University Division of Endocrinology. We are excited to bring another one of our short videos on osteopetrosis today. Our goal with these videos is just to be able to bring some reliable information on some of the rare diseases that we study here at Indiana University. We understand the difficulty in finding reliable information on the internet or with providers. So our goal with these videos is to help bring some of that to you. If you have questions after our discussion, we'll be more than happy to try and answer those. We just always, please remember that this is for educational purposes and should not take the place of care or advice from your own personal healthcare provider. So if there's questions that you have, feel free to shoot us a message. Just please don't post any personal information, as we will have to delete that information. We don't want to share those kind of things around. So our other thing is we'd like to come up with new ideas and new discussions for these videos. We will probably do a series over XLH in the near future. After we do a few more, probably on osteopetrosis. Our goal is to also do one on kind of the guilt associated with passing on a hereditary disease, maybe a video on advocacy for rare diseases. So those are things you can look forward to in the near future. Today's discussion is going to be led by Amy Katz. She is a coordinator here at Indiana University with our division and has been working with the osteopetrosis study we have going. Our speaker today is Lynda Polgreen. And can you go to the next slide, Amy? Mm-hmm. One more, just so I can have her bio. Lynda is from the Lundquist Institute at UCLA Harbor. She's an associate professor of pediatrics at the David Geffen, I hope I'm pronouncing that right, School of Medicine at UCLA. And Lynda's been doing osteopetrosis research for quite some time, has done multiple trials. She's also an investigator on trials for other rare metabolic diseases. So we are super excited to have her with us here today to share information about kind of the diagnosis and management of osteopetrosis. So with that, Amy, I'm going to turn it over to you to move forward with the slides. Thank you.
Thanks, Marian. And thank you, Dr. Polgreen, for joining us today to discuss the diagnosis and management of osteopetrosis. We're going to just kind of hop right into the topic of discussion. So in our last video that I did with Dr. Econs, he discussed, the certain types of osteopetrosis, and he mentioned briefly, specifically using X-rays as a way to diagnose osteopetrosis. So I was hoping, can you explain this a little bit further in terms of X-rays and what should providers be looking for when they're trying to make that type of diagnosis?
Sure, I'd be happy to. So why don't we just take a look at a few X-rays where we compare the bones in a patient with osteopetrosis to people who don't have osteopetrosis. And as I think was mentioned on the last video, the only thing that's really needed for the diagnosis of osteopetrosis is radiographic findings, so X-ray findings of this increased bone density. And what we look for when we're making that diagnosis, one of the things that is characteristic for osteopetrosis is shown here. On the left, you see what we call a bone-in-bone appearance. And so what that means is, I think you can see this here, and I don't know if you can see my cursor or not. Okay, so you get this this bone, what looks to be inside of another bone, and similarly down here. Versus if you look over here, you don't have this increased white density, white area inside the external part of the bone here. And so that's why we call it a bone-in-bone appearance. And you can see that in the long bones in individuals with osteopetrosis. And so when we see that, that is really diagnostic of this and what we use. There is some other characteristic findings though as well that we look for. So the other one of the two that I'll just point out during this video is this, what we call a sandwich vertebrae. And so again, the X-ray for a patient with osteopetrosis is on the left and the normal spine on the right. And so what we're looking at here is the spine, so the back, and looking at it from the side view. And typically you see very thin white lines on the top and bottom of each of these vertebrae. So these, just to orient you, like these little things sticking out here is the spine process that you feel on your back. And then these are the vertebrae that your spinal column runs through. And so you've got very thin white line on the top and bottom at normal. And then if you look over here, I think you can see what we call it sandwich. It looks like a sandwich. So you've got a much thicker white density, white line on the top and bottom of each vertebrae with a little darker area in the middle, giving it that sandwich appearance.
I was just going to make a quick comment on the bone on bone on the slide before. That's also called endobone, right?
Yes.
Okay.
Exactly. Yep. Endobone's another name for that. Yeah.
Nice. So kind of moving along with, this process, this diagnostic process, could you also clarify, using specifically bone biopsies as part of that, process?
Yeah. I would say that there's really currently no role, generally speaking, for a bone biopsy in the diagnosis of osteopetrosis. Again, it can be a clinical diagnosis entirely based on radiographs. I do recommend, and the general recommendation currently is that the diagnosis is confirmed with genetic testing. And the reason for that is because there are a few different genes that are associated with osteopetrosis that can predict some unique complications of the disease, or predict severity of the disease. And this is a bit more relative to the autosomal recessive form versus autosomal dominant form, because autosomal dominant, it's primarily a chloride channel mutation, so the CLCM7, versus the autosomal recessive form, there's multiple genes that result in that form. And some of those genes, for example, are associated with some complications with the kidneys or some problems with development and CNS disease. And so they become important there. I'd say bone biopsy used to be used in the setting of autosomal recessive osteopetrosis when deciding to treat with hematopoietic cell transplantation, which is also called bone marrow transplantation. Reason for that is because it used to be they literally pull bone marrow out of the bones for bone marrow transplant, which is where that name came from. Now we generally use the term hematopoietic cell transplantation because they can just take the blood forming cells out of the blood, the peripheral blood, by stimulating your bone marrow to make those cells, these stem cells, and they don't have to go right for the bone marrow. So hematopoietic cell transplantation is basically the same thing when people say bone marrow transplantation.
People, I understand. So it sounds like bone marrow transplantation and hematopoietic. Did I pronounce that right?
Hematopoietic.
Oh, hematopoietic. You say that more eloquently.
I've said it more often, probably.
Probably. So those are more forms of treatment, right? And whereas the bone biopsies you use more on the diagnostic part, just to kind of clarify. Great.
Yep, exactly. Yep. And the biopsy was used to determine if it was a type of autosomal recessive disease that could be effectively treated by transplant.
Okay.
Now that we have genetic testing that determines that, the bone biopsy really is not indicated. I could only see it being a rare situation if you'd have to, I guess, have a gene that you didn't know if it was going to be what we call osteoclast rich, osteoclast poor, whether it's a gene that would allow for transplant to be effective. So, I guess trying to be succinct with this, basically, there are certain mutations that are in the osteoclast itself. And hematopoietic cell transplant or bone marrow transplant can give that osteoclast, a new healthy osteoclast, back to the patient. But if the problem is in something that is external to the osteoclast, that's making the osteoclast not function, not mature, then you can't fix that with a bone marrow transplant, because, for example, if it's a problem in the other bone, the other cell in the bones that actually makes bone, so osteoblasts, You don't get that from a bone marrow transplant. So that's why it's important to really understand where the problem is when thinking about HCT or BMT as a treatment.
Sure.
But again, all very much more relevant for the autosomal recessive form.
Yeah, that was a great explanation. So kind of moving along too with some other factors and ways to diagnose osteopetrosis. Sometimes, we see people talk about DEXA scans. Can you kind of further explain how those are used in terms of specifically maybe numerically Z-scores versus T-scores, but also, what do DEXA scans look like in an individual that may have osteopetrosis?
Sure. So I guess the first comment in DEXA scans, they're not needed to make the diagnosis of osteopetrosis. Again, it's really just x-rays. They're often obtained as kind of a confirmation, I guess you could say, because a DEXA scan, it measures bone mineral density, and bone mineral density is really increased and bone mass in people with osteopetrosis. And so they'll have abnormally high what we call Z-scores or T-scores, and I'll explain in a minute the difference between those. But so it's really the x-rays that make the diagnosis, and a DEXA can be used to confirm it. The Z-scores tend to be, so a normal Z-score would go up to, let's say, +2. And in osteopetrosis, they can be, 5 to 20, which is, clearly very high. And I think a lot of people are familiar with DEXAs because they are just so, there's so many of them out there in the community because they're used all the time for the diagnosis and management of osteoporosis. And so you can see here the DEXA machine on the left, and what they look at is the femoral neck. So this is the top of the leg and going into the hip here. And so they measure the density there. And then it also looks at the spine, the lower spine or the lumbar spine, and measures the density there. And when it measures the density, it gives you a T-score and a Z-score. And so it's up to the physician interpreting it to know which is the one that is indicated to use in that population. And so I guess first to mention the T-score. So the T-score is taking the patient's bone mineral density and seeing how it compares to this reference database that is basically around 20 to 30-year-old women who, because that's where you reach your peak bone mineral density, which is what I show in this figure up here. And the reason for that is really completely related to osteoporosis and fracture risk. So it's not really relevant to osteopetrosis because the studies that have been done using T-scores clinically are really studies looking at the fracture risk based on how far below that peak, young adult female bone density you are.
So someone like me, someone in their late 20s.
Yes, you are at your peak bone density. I always hate to say it's all downhill from there, but in the bone mineral density, it is. So take care of your bones. But yeah, exactly. So you reach your peak and you go down. But for osteopetrosis, it's not relevant because their fracture risk is not related to their T-score and actually not related to the Z-score likely either. So what the Z-score then is taking your bone mineral density and comparing that to a group of people, again, this reference database, that where people are the same age, sex, and race or ethnicity. And that just tells you, for a woman at your age, how do your bones compare to other women your age? For women my age, how do they compare to another woman my age, and not just that young adult female mean? And so this is where I think it's Z-scores are a little more meaningful for osteopetrosis. Again, they don't impact the management really, but they give you an idea, I guess, of how quickly maybe the bone mineral density is increasing. Is it increasing? So we use this more in research settings, honestly, than a clinical setting to make any. It's not used in a clinical setting, I would say, to really make management decisions. But in research studies, we use this to see how the bone mineral density is changing over time relative to other people their age. So the figure on the top, I just give examples of that, you know, the yellow dot is a person, and they're being compared to wherever this curve is for that person with the same sex and race. So does that make sense? Did that answer that question?
Yeah, okay. That was really good explanation. Kind of moving along, focusing more on the actual management portion of you know, our talk today. We hear, you know, a lot about how taking calcium and how vitamin D is good for bones. You know, how would this help those who have osteopetrosis?
Yeah, there's, I think, some misconceptions out there that because people with osteopetrosis have a lot of bone, that maybe they don't need calcium and vitamin D, that they have so much calcium already in their body, why would they need more? And if we give them calcium, are they going to get high calcium in their blood because they already have so much there? But what needs to be remembered is that the reason they have so much bone is because the cells that take calcium out of those bones are not working. So it's all, the calcium is just trapped in the bones. You can't pull it out to keep the calcium normal in your blood as easily as people without osteopetrosis can. So people without osteopetrosis, if you're, for example, your dietary calcium goes way down, your body will naturally tell your osteoclast to pull some of that calcium out of your bone to keep the calcium in your blood normal. And that's because calcium is critically important for all sorts of things, but in particular, for example, your heart function and rhythm and things like that. And so since they can't pull it out of their bones, it is still important to make sure that they have adequate dietary intake of calcium because they are mainly going to be relying on that to keep the blood calcium normal. We don't see that it causes a worsening of increasing the bone density. So the recommendation is to just follow what's shown here, which is the Institute of Medicine recommendation for calcium and vitamin D intake. This was a working group that put this together back in 2011, and there's been some controversy around the vitamin D side of it, but from the calcium, I think it's pretty straightforward. I show here the recommendations for age. So the RDA, that would be the amount of calcium that they would recommend that one takes with these different age groups and other factors such as pregnant or lactating. And then there's an upper limit, but I would say people should just really focus on the RDA with osteopetrosis to ensure that they're getting that in their diet. And go ahead.
I was just gonna say that's typically in like the calcium at least is typically in a, you know, a tablet form, right? That you can just take and buy over the counter. And even the vitamin D, which I didn't know if you could kind of talk about what the difference between vitamin D2 and 3 is as well, really quickly.
Yeah, definitely. There are many formulations of calcium and vitamin D individually or combined that are over the counter. It gets kind of confusing for people sometimes, I think, in terms of what to choose. So calcium, there's calcium carbonate, I'd say, is the main thing people take. There's things like Tums, there's other chewable type of things with calcium. But the important thing, I guess, with calcium to just let people know is when you look at these numbers, so if you're 51 to 70 and 1200 is the number you're wanting to get to, you don't look at the number on the front of the bottle. You need to turn it around, actually. And if you look on the back, it'll say calcium in the milligrams. And that's going to be lower, 40% lower than the number on the front. And so it's just the number on the front is what we call a salt. It's the calcium carbonate. And if you look on the back, it gives you the actual amount of calcium. And so that's the number you should look at in terms of getting enough to reach this RDA. Having said that, you can, of course, get calcium from dairy products. So milk, there's about 300 milligrams of calcium in an 8-ounce cup of milk. So you can get it there in dairy and things. But yes, there's various supplements. When it comes to vitamin D, D2 and D3, most of the products right now over the counter are D3. The prescription high dose form is D2. When we treat with a prescription of high dose vitamin D, we use D2, but that's simply because there's not a prescription high dose formula for D3. And we want to make sure that we know the amount of D we're giving when we're treating with high dose vitamin D for like severe deficiency. And unless it's a prescription, you never really know for sure how much of the vitamin's actually in there. So
Yeah.
that's, I guess, why the high dose is D2, just because there's a prescription. Over the counter, either D2 or D3 is fine. There's some talk about a little benefit to fixing things faster with one versus the other, but generally either's fine. But most of what you're going to find is D3.
Sure. No, that was super helpful. Go ahead.
I was just gonna say, and the recommendations there for vitamin D is here, but I want to point out that although the Institute of Medicine says to keep this 25 hydroxy D level at 20, the Endocrine Society and those of us that see patients with osteopetrosis really do recommend keeping that at 30. And that's in part, I would say, because there's potential benefits of keeping the vitamin D above 30 in terms of immune function. And given the higher risk of infections in this population, I think it's really important that they keep the vitamin D, the 25 OHD over 30.
Yeah, that certainly makes sense. And even just like general knowledge that I can take away about calcium and vitamin D2 and 3. And kind of moving towards, though, we've heard and all about some treatments for osteopetrosis that have been done, either in research. Dr. Econs and you as well. I was hoping, can you highlight some of the reasons why, some patients have taken calcitriol as a therapy or other forms of activated vitamin D. So can you explain actually the effectiveness of these two therapies here?
Yeah, so calcitriol, the history there is Dr. Lynda in the 80s and 90s had done some work looking at high dose calcitriol, which is it's a type of vitamin D that your body can't regulate. So the type of vitamin D you get over the counter, it's hard to be toxic with it because your body is able to just put it in storage if it doesn't need it. Versus this form of vitamin D, it gets in your body and it just triggers the whole system to increase calcium in the blood. And so when he did the studies, he had people on low calcium diets and on high calcitriol. And although there was some early findings of increasing osteoclast function and some white blood cell functions in terms of infection, ultimately the patient's just disease progressed. This was a lot of in the autosomal recessive osteopetrosis, so they went on to still develop bone marrow failure. And so I'd say that combined with, just going to go to the next slide. That combined with some of the data out of Dr. Econ's group a few years back, which showed in an animal model when they treated the mouse model of AD02, the autosomal dominant form of osteopetrosis, with high dose calcitriol, it actually increased their bone marrow density. So it made things worse than the mouse model. So there doesn't seem to be enough clinical data suggesting a benefit. The mouse data suggests there's actually a harm. And so we do not recommend right now the use of high dose calcitriol in osteopetrosis.
Okay.
So interferon gamma is another experimental therapy that, as you mentioned, both Dr. Ekins and I have been looking into. This comes from, again, early studies by Dr. Lynda Key. He had done work with interferon gamma in the autosomal recessive osteopetrosis, found some benefits in about 18 to 20 patients. Based on his work, the FDA approved it for the severe infantiles, the severe form of autosomal recessive osteopetrosis. But nothing was ever looked at in the more attenuated autosomal recessive or the autosomal dominant. So Dr. Ekans, again, in the same paper, looking at the mouse model of AD02, found benefits of interferon gamma, found that it had decreased the bone density in these mice, looking at it in a few different ways that they can do in mice. And it suggested that it might help. So he conducted a clinical trial with his group. I believe it was 18 weeks of interferon gamma, looking at change in the markers in the blood that tell you, are the osteoclasts, the osteoblasts, are they changing how much they're functioning? And in that 18-week trial, which is published also, They didn't find any significant change in the bone markers over those first 18 weeks. I did a trial myself and Dr. Paul Orchard at University of Minnesota, focusing more on the severe AD02 and the attenuated autosomal recessive form, because we had been seeing poor outcomes with transplant, bone marrow transplant in that population. And we had 5 in our study, and we're just getting ready to submit it for review and hopefully publication. But what we found was that it's intolerable, which Dr. Econ's group found also, unless we added prednisone to it. So the trial was really useful in figuring out actually even how to use it in this group, because they had such severe pain and what we call a flu-like reaction with it that makes them feel basically like they have the severe flu for 3 days. But if you give prednisone, it took care of that. So one of the 5 kids that was on prednisone the whole time, we do see that there was no change in the bone mineral density using a few different ways to look at it. And there was another individual that made it to 9 months, and in him there was an increase in his bone mineral density before the study, and then no change during the study. The problem is we don't have good natural history data to really say, okay, is that what would have happened anyway? Because then we didn't see a big change in bone markers either. So for that reason, from both Dr. Eakins and I really feeling like we needed natural history data and some new therapies potentially in the pipeline, we've now started some natural history studies. One online registry, yeah, exactly.
Yeah.
And then the in-person one that's being done at Indiana. And so hopefully with the data, we can better interpret these new experimental therapies.
Yeah, that was super informative. And really interesting to hear, where you your next steps in terms of potentially finding a treatment, something a little bit more solid for individuals who have this condition. And, I guess what do we do moving forward? You talked about, just keeping on with the natural history study, doing research, but, in terms of right now, what can individuals kind of do who have osteopetrosis?
Yeah, it's a good question, and I don't have a great answer. But what I would say is it's important to find a team of providers who, if they don't have experience treating osteopetrosis or other high bone density and osteosclerotic diseases, they're at least willing to learn and reach out to people who do know. There's a guidelines paper that we've written that I'll give the reference on the next slide, that can be given to providers to help them, and it gives them names too from the authors on people to contact. But what's shown here is just the multiple different specialists that are really needed for the different complications of this disease. So unfortunately, there are a variety of complications that result because of osteopetrosis, and it's what we call symptomatic approach right now, meaning if you have pain, you go see a pain specialist. And I strongly recommend individuals who have pain to seek out a pain specialist and not rely on their primary physicians or their orthopedic doctors to treat the pain, because those individuals generally are not trained in the multiple ways of managing pain. And pain is a big issue for patients with osteopetrosis. Another is the chronic anemia, and that can really impact quality of life. So really having a hematologist who understands what can be done and when to go to transfusion is important too, as are all these specialists. But it's really symptomatic at this point.
Mm-hmm.
And here's just the reference if people are interested. I've heard back from some patients that they find it really helpful to give this to their providers. We got everybody together multiple times and did surveys to have everybody come to an agreement on what they recommend the management in certain areas would be. And so this just goes through every system that I just mentioned and gives recommendations.
Yeah, I think this is one of the most useful kind of tools that we have right now, in terms of, I've talked to many individuals that, they have to be their own advocate in this scenario. And this is like, knowledge is power. And this is a great way to really be informative in the best ways we can. And
Great.
yeah.
Yeah.
So
All right.
I'm going to have Marion wrap up.
Dr. Much. That was, just so informative.
You're
Even
welcome.
working in this for a while, every time I hear someone present, I feel like I am able to capture, just another little bit of information. So thank you again for
Happy
your
to do it.
time. We will be happy to have you back and do more as your time allows, of course.
Happy to do it.
If those who are watching have suggestions, our Facebook information is there. We are also at IU Endobone, right, Amy? At
Endobone at iupui.edu. Close.
Yeah. So feel free to send us an email. Again, if you have questions about the presentation, we'll be happy to go over those as we can. Just don't provide any personal information, and we can't provide advice. If you're looking for information on osteopetrosis, there is the Osteopetrosis Society, or OPETS, and there is information on their website, additional contacts, information to provide your physician. There's also a couple of Facebook groups for people with osteopetrosis, and many of you may have found us through those groups. So I think one of the important things with rare disease is to know that you're not alone. There are other people out there who are struggling with the same things that you are. So it's very important to try and network with those folks. So we always encourage people to join those groups. If you have any questions, feel free to reach out to us. We look forward to seeing you guys again in the near future with our next presentation. So thank you guys for joining us. Have a great day.